Doctor series created by Nick Beirano and the marketing department has been a wonderful success and a great way to reach out to the community. And we have had varying numbers. I'm given between 8 and 12 of these now. Nick, what is the accurate number? 8. And each occasion it seems like we have more attendees, and we also have this streaming on the web, which is really neat too. So I'm Don Kersey, and I'm an ear, nose, and throat doctor. I've been in town for a while. We'll move on. I'll give you my medical training. In 1964, I started medical school at USC. And after medical school, I went to internship at Santa Clara Valley Medical Center. And then I was in the Army for 2 years. 1 year in Vietnam as a doctor for the Army, and the second year at Fort Ord, also a doctor at the base there. Then I had 4 years at Stanford in ear, nose, and throat and head and neck surgery. And then I came to Ukiah in 1975. Joined a guy named Matt Howard that some of you know. And he and I were together 15 years. And then Matt became an attorney and left the area for his practice and then came back. And then I was by myself a couple years, and then Lori Spence, Dr. Spence, joined me, and we've been together about 22 years now. And I've been here a total of almost 39 years now practicing in Ukiah. And some of you I've known that long. You know, Pete Passoff and I were Cub Scout leaders clear back in the mid-70s sometime. And that was the last time the lake went dry. It was when we set out rockets out there in the lake when it was dry about 1976, 77, something like that. We hope it won't go dry this year. I have a wife, Linda, and she is now a third grade teacher at St. Mary's, but she was also on the Ukiah Unified School District Board for about 14 years. And we have 2 boys. They're both teachers. One son teaches up at Ukiah High School, and the other one teaches at Windsor. And the one here in town is married to Jendi, and Jendi has Indigo Productions, which is a photography and marketing business she has downtown next to Shots. I don't know if you've ever seen that down there. Anybody who knows Jendi knows she moves about 120 miles an hour and always has a new idea every minute. And, seems like a daughter to me now after all these years. So in terms of community and family, our family, even though we weren't born and raised here, we feel like we're part of this community. And I think one of the blessings of a small community is to have this type of thing. If you were in a large community, it wouldn't be nearly as intimate. You wouldn't get your questions answered. And I hope to do some of that for you tonight. Just an overview of what we're going to do tonight. It's going to be kind of a potpourri of ear, nose, and throat. We'll start with the ear and go on to the nose and sinuses, and then we'll go on to the throat. I was told that probably a good thing to hit would be sleep apnea. I think that's something that's not new, but something that everybody is concerned about anymore, so we'll certainly spend some time on that tonight. So we're going to start with the ear, and of course when you talk about the ear, the first thing you got to talk about is wax. What do we do with the wax in our ears, and why do we have it? So the wax in your ears actually contains a little bit of an antibiotic, and it helps prevent infections. It's also sticky, so it stops bugs and little things from crawling in there. But a lot of people like to try and clean their ears. Whether or not they have much wax, they really are bent on cleaning their ears. And of course the Q-tip, as the gentleman on the left demonstrates, is probably the most popular way of cleaning the ears. So a couple of things about wax. Most of us don't need to have our ears cleaned at all, or if they need to be cleaned, just the very openings to the ears so that it doesn't look like your ears are dirty. And if you're going to do that, you can use a Q-tip, But if you're going to use the Q-tip, grasp it so that you're grasping it real close down here instead of way out here, so that you're not going to shove it through your eardrum if you suddenly jerk or the phone rings or something like that. I had one lady who was watching a soap opera and she was cleaning her ears with a Q-tip, and she got so enamored with the soap opera she forgot she had put the Q-tip in her ear. The phone rang, she turned her head around, the Q-tip hit the sofa and jabbed her right through her eardrum. So you got to be very careful if you're using Q-tips, and grab them very close down and just clean the outer portion. Now, if you get a buildup of wax where you can't hear and you're having problems, then we're talking about other ways of cleaning your ears. If you go to general practitioners, they're going to use irrigation most of the time. Dr. Spence and I use suction and a microscope. And the reason we do that is we have a suction and a microscope. I think if the general practitioners had it and had that available, they would use it too. But the very best way is to suction it out with the aid of a microscope so you can see what you're doing. Short of that, and the way to get it out, and the way we did it in the Army, is you put some oil in your ear for several nights because the oil will soften up the wax, and then use, like is being used here, one of these bulb syringes that you used to use for the kids to get all the snot out of their nose, and use some nice warm water. And you want the temperature of the water to be the same temperature as your body. If it's too hot or it's too cold, it's going to make you dizzy when you irrigate it. But if you soften the wax first and then you use the irrigation, almost always that'll get rid of the wax. Now, you've got yourself a wet ear canal in there. That's not a good situation. So the next thing you do is you take some isopropyl alcohol. So you take some rubbing alcohol and you dilute it half and half with some white vinegar, and you just put in 4 or 5 drops of that in each ear, and then you won't get an ear infection. I see a lot of people who have irrigated out their ears, left their ears moist, and the next thing you have aspergillus, which is a fungus growing in there, and it gets very painful, and you get this black discharge coming out of your ears, and you're wondering what's going on. So cleaning your ears just on the outside, use your Q-tips, but just on the outside. If you really got a buildup and you think your hearing's going down, you can try that. Short of that, I wouldn't be doing anything else. Don't use bobby pins, keys, any other foreign objects. Your grandmother told you nothing smaller than your elbow goes in your ear, so always remember what your grandmother told you. And so that's kind of it with wax. And by the way, as we go through this, I'm not going to take questions as we go through it, but at the end we'll have plenty of time for questions. So if you have questions, just jot them down, and we'll talk about them as we go through here. So the next thing that we're going to talk about are ear infections. So this is a what we call a sagittal section of the ear. So you have the pinna here, then you have the ear canal right in here, then you have a little eardrum right there, and then you have some ear bones right here, and then you have the inner ear right here, and then you have the balance mechanism up here. And this right here is the eustachian tube. So this is a tube that goes down from behind the eardrum down into the area behind your nose way in the back. So when you go in the mountains and you hear your ears pop, what's happening is air is going up and down this tube right here. Every time you swallow, you actually get a little motion of air going up and down that tube, and that equilibrates the air behind the eardrum. If you have a stuffed eustachian tube, say this gets stuffy, maybe because of allergies, maybe you've got a bad cold, maybe you've got an infection with strep, so it gets swollen. Now you can't get any equilibration behind the eardrum here, and you're going to build up fluid. When you build up fluid, it sounds like you're talking in a barrel. You go to talk, what's wrong? I got water in my ear? Well, you do, but it's behind the eardrum. Next thing that happens, you get a virus or a bacteria in there, you start getting an earache. And then if nothing is done about that, the earache can go on to a perforation where suddenly you have a rupture and you have blood and pus come out of your ear. Through the years, we have been able to get rid of ear infections in this portion of the ear with the advent of better and better antibiotics. About 30 to 40% are actually viral, but a lot of those will go on to become bacterial also. So it is important if an earache continues for more than 24 hours, and especially if you're starting to get a fever, that you do need some treatment for that. There have been a lot of studies about not treating these. A big study came out of Sweden, and the study was that they randomized two groups of children. They treated half of them and they didn't treat the other half. You can only do this in a system where you have national health care. And I'm not saying that's good or bad, I'm just saying they did this. And the kids who had their eardrum rupture and the pus came out actually did as well as the kids who were treated in the long run, meaning their hearing was not affected and the eardrums all healed and it let the pus out. So nature does have a good way of dealing with this. It's just that it's painful, and I think probably antibiotics are a better answer. So those are the ear infections that you can get in this portion of the ear. Now you can also get infections in this portion of the ear, and this is called labyrinthitis. So that would be involving the balance center and the inner ear, which is called the cochlea. When you get an infection in there, you feel like you're on a merry-go-round, the room starts spinning on you, you start getting nauseated, your hearing might go down in one ear, and this type of infection definitely needs to be treated. And usually it's treated aggressively with antibiotics and sometimes steroids to calm down the inner ear so you're not so dizzy. I don't know if any of you have ever had those kinds of infections. They're not nearly as prevalent as the routine infection that we're talking about in the middle ear. And then lastly, the outside portion of the ear canal where your wax can be, this can get swimmer's ear. So I think any of you who had kids in dolphins, or you know about dolphins and the kids swimming all the time, invariably they're going to end up with a painful ear after a while because they have so much water going in their ear, it breaks down their natural immunity, and pretty soon they have an ear infection in that outside portion of the ear, and that requires ear drops, and that will heal that up pretty quickly. So the three types of infections you can get are the outside portion of the ear canal, the swimmer's ear, the middle ear, which involves what we call otitis media, where you can get an infection there, and the inner ear, which is the labyrinthitis type of infection. Next thing we're going to talk about is hearing. As I've gotten older, this has become a topic dear to my heart. So as we look at the audiogram here, this is an audiogram. The left ear is conventional as an X and the right ear is an O. Also, right ears are red, right is red, and blue is left. So minus 10 to 0 would be perfect hearing. This is like a baby at birth. By the time you're 30, your hearing is down about 10%. By the time you're 40, it's down 15% or so. By the time you're 70, it's usually down 30 to 40% or so. And then after 70, it starts getting down more. So normal hearing is in this range here. If all of your scores were in the white area here, that'd be normal hearing at low frequencies, mid frequencies, and high frequencies. As you get older, your hearing drops off in the higher frequencies. So you notice in rooms that are noisy, you're having trouble talking to people. You notice that if there is a child, say a grandchild who has a high-pitched voice, you're having trouble understanding them. Teachers will come in saying they don't understand their little kindergarten students anymore because the teacher is now 65 and her hearing has gone down in high frequencies and the children have the high frequency voices and you can't understand them. So when you lose your high frequency tones, which is the common thing that you lose as you get older, if it is severe enough, so here's moderate hearing loss here. So if you're in the moderate range to severe in the higher frequencies, you need to be thinking about hearing aids. So the topic of hearing aids, this is a multi-billion-dollar business. Anybody who gets a AARP magazine knows this. I mean, there are ads all the time. And hearing aids are probably oversold. Just as a reminder, in the state of California, there is a consumer protection law that if you were to buy a hearing aid, and you change your mind within a month and you take it back, they have to give you your money back for that hearing aid. Maybe they can charge you $50 for fitting it or something like that, but they're required to give you your money back. And that's because it's been recognized in the past. There were a lot of people who came in, went up to the Discovery Inn or Luann Motel, whatever it was at that particular time, set up their business for the weekend, sold a bunch of hearing aids, and then left town. Well, they can't do that anymore. They have to be responsible for what they're doing. So when you get the recommendation you get a hearing aid, you should have a good audiogram by an audiologist. We have two audiologists here in Ukiah. One is White Andrus and the other one is Glennis Tambernini. They both do excellent work. They both are very fair, and they will not recommend a hearing aid unless you really need one. When you get fit for a hearing aid, you don't always have to go to an audiologist for that. So you need a good hearing test with an audiologist. But if you have a Costco card and you go down to Costco, Costco does a good job fitting hearing aids. You bring in your audiogram, they'll look at it, and they'll fit you with a good hearing aid for a good price. The follow-up is a little bit dicey because we don't have Costco in town yet, and so you have to go down there, and that can become a problem. But hearing aids can be fit very well by Costco, and so don't pass that up as a possibility if you're thinking about getting a hearing aid. The next thing we're going to think about here are nose and sinus problems. And just to give you an overall view here, when doctors talk about sinuses, they talk about these bony cavities that are here and up in here. So these are called frontal sinuses here. These are called maxillary sinuses. When we say our sinuses are stuffy, a lot of us mean that we can't breathe well through our nose. When a doctor says the sinuses are stuffy, they're talking about there's some lining of the sinuses here that has thickened or has become inflamed. So when I'm speaking of sinuses, I'm speaking about the bony cavities here. Speaking about the nose, we're talking about this area here. So the first thing that can happen to the nose, because it's hanging out there throughout our entire life, is get sun exposure. If you get enough sun exposure, you're going to start to have areas that kind of break down, ulcerate, get a little blood, and this is a typical look of a basal cell carcinoma, which is a type of skin cancer. It's a garden variety skin cancer. This type of skin cancer here, when it's this extensive, almost always requires some type of surgery to get rid of it. And when the surgery is done, it should be done with some type of monitoring of how the surgeon is doing. Meaning, you've heard of Mohs technique probably, where the sections of the surgical tissue is then looked at the time it's removed. Frozen section, we do that here in the hospital. It's the same type of thing. So when it's removed, it's looked at the same time it's being removed to make sure all of it is gotten. And then it has to be reconstructed. And typically this would be reconstructed by taking a flap of tissue here, then moving this tissue onto the nose here. You don't want to let it get this far. Any non-healing sore on your face, particularly your nose and lips, needs to be investigated. And sometimes it's not as severe as this, and it can just be frozen with liquid nitrogen, or it can be just shaved off with a scalpel, and that's the end of the problem. So anytime you get a non-healing sore that's on your nose, it's on your lips, you give it a few weeks. If it's not better, you got to get in either a dermatologist or see Lori Spence or me, so we can take care of this. You don't want it to get this far. The other thing that happens to the nose, because it's sitting out there, is you get into people's business and they hit you in the nose. So the typical nasal fracture, and this gentleman's displaying that, you get black eyes, you get a bloody nose, and you get a nasal deformity. Now, I fixed a lot of fractured noses in my day, and the first thing you have to realize, they don't need to be fixed immediately. So a lot of people will call and say, I got a fractured nose, it's got to be fixed. You want to let the swelling go down, because the first thing that happens, it really blows up. I mean, it's huge. And you can't see what you're doing. If you're the doctor trying to give a good straight nose, and the nose is all swollen, you can't tell where the bones are and where they're not, and where the cartilage is and where it's not. And so you got to let at least 10 days go by and let the swelling go down. And commonly take an x-ray. The x-ray is usually more for the insurance company than for you, to help you. And then we straighten it out, and we can straighten it out sometimes in the office, sometimes it has to be in the hospital, depending upon the severity. So the things to remember when you hit your nose, unless you get a bad bloody nose and your eyes turn black and you can see a deformity in your nose, you haven't fractured your nose. And that goes for all the grandkids and kids, and you know, they'll come in and they've fallen on their nose and you're wondering whether it's broken or not. Well, did they get a bloody nose? Are their eyes turning black or blue? Can you tell, is there any kind of deformity there? So those are the things to look for, and you can do a lot of kind of self-doctoring so that you don't have to call up and actually have the child seen and have whoever it is seen. This is something, however, that usually needs to be seen. So this is a foreign body in the nose, and this is a marble. And this becomes a very personal thing. So when I was in training, my wife calls me one day in the afternoon, I'm in clinic. She said, our younger son just put a rock up his nose. And I said, well, you better bring him in because we've got to take it out, because you're worried about it continuing on back. Depending upon the size, it can go right and he can aspirate down his lungs, and we got to take it out of his lungs. That's much worse. She said, okay. So she bundles him, puts him in the car seat, takes our other son, puts him in the car, takes her Volkswagen. She's driving up to Stanford, and he sneezes, and our older son says, Mommy, it came out. Because our younger son didn't talk till he was 5, so the older son was talking for him. But Linda forgets to call me. I, in the meantime, have notified the Department of Anesthesia. We were getting ready to take the child in so I could get the rock out. Linda calls me from a store. She's going to the market. She forgot to call me, and she called me and said, by the way, it came out. Most of these will not come out. Once it gets this far up, and this doesn't look very far up, especially round things, you can't get any grasp on it. You can't get behind it. The child's panicked. Everything you do hurts, so usually you end up having to put him to sleep to get it out. And had a lot of foreign bodies through the years. Sometimes they get so far up you can't see them, but the hallmark of a foreign body that's up there is a foul-smelling discharge from the side where the foreign body is. Sticking like toilet paper up their noses or something that's just sticking up in there, and it's just kind of, pretty soon it kind of gets sour, pretty soon it's infected, and pretty soon pus is coming out, and there's something up there, and the child needs to be seen and it needs to be removed. But that's usually a child thing more than an adult thing. Hopefully. So talking about sinus infections, and this is a fair representation, but we're going to go back to our other slide here in a minute. So this is a profile of the nose. There are these three things right here. Now let's see, what are those? Those are called turbinates. Turbinates are swellings in your nose. They act as the humidifiers. They warm the air, and they put a little moisture in the air as you breathe. So before the air goes down into your trachea and into your bronchial tubes, those nice turbinates right here, where the air kind of flows through, they'll warm up the air and moisturize it. Sometimes those turbinates will get big and block the nasal airway, and then we trim them down. The other thing that happens is right beneath those turbinates is where your sinus cavities actually come into the nose. So when you get a sinus infection, and I think everybody has had, a sinus infection or, had the symptoms of one. So this is the turbinate. So you saw it just a minute ago on the side view. This is what it looks like from the front view. And most of you don't know about turbinates, but turbinates play a major role in sinus infections. They play a major role in obstruction of the airway. So this turbinate swells. When it swells, this sinus over here can't drain because the drainage point is beneath the turbinate. So now with the turbinate swollen, this sinus can't drain, and the next thing you know, you're getting pretty tender. This tooth is getting kind of tender because the root's right up about here. So you got a toothache, you got a face ache, and you're starting to get fever and you're feeling miserable. So what are we going to do? So that's a typical sinusitis or acute sinus infection presentation. First thing you got to do is you got to get this thing shrunk down here. And so what you do is you go down and get Afrin spray or one of the sprays that you buy over the counter. You spray it up your nose, and then you put your head over some steam. A saucepan works great. Put some water in there, maybe a little half teaspoon of Vicks, and then you heat it up so it boils and comes nice steam. You put your towel over your head, over the steam, nice breaths. That steam now goes up into the sinus, and it mixes with this stuff here that's like 40 weight oil, turns it into 10 weight oil, and now it comes out. So it goes from thick to thin, comes on out, pressure's relieved, tooth gets better. You've been your own doctor. Bill yourself. That's a good deal. If it gets worse, you got to get on some antibiotics. But it's always worth a try to decongest the nose, get some steam up there, and see if it'll take care of itself. And if you do that for a couple of days, and these will come on with a common cold. You know, we really haven't hit cold season yet. I'm not seeing that many colds. Maybe you guys are, but when you get your cold, that's when your turbinate gets swollen, that's when the sinus backs up, and that's when you need to decongest and do your steam. And then it won't turn into something that you got to be on antibiotics for. If you get into chronic infections, then you got some problems. So here they're showing a septal deviation. So you're looking at the nose here, and your nose has a divider right here. If it's deviated like this, then we call it pushed over, deviated, displaced, whatever you want to call it. But when it does that, it can occlude or stop the sinus from draining, and then you end up having to get your nose operated on to straighten the septum so the sinus can drain so you don't keep getting recurrent infections. And that's one of the many kinds of things you may have to have done if you get chronic sinus infections. So going along here, sleep apnea. So this has become a major problem, and part of it is the obesity epidemic that we have going on in the United States. With so many people gaining weight, you have to remember when you gain weight on the outside, the inside of your throat is gaining weight. So if you gain weight out here, you're also gaining weight inside your throat, and it's decreasing the diameter of your airway. And when your airway decreases diameter, you can't get air down there nearly as easily. Also, as we get older, our tissues tend to get a little bit more floppy. We don't have the tone. So all you got to do is look in the mirror, see things aren't as tight as they used to be. Well, they're not as tight in your throat either. So that the uvula, the thing that hangs down in the back, tends to be more floppy. The tongue doesn't have the tone that it used to have. And so now if you're a little bit overweight, if you have the tissues that are more relaxed, when you lay down on your back, your airway really gets compromised. And now when you're trying to breathe at night, you can't get the air through your nose easily and down your throat the way you usually do. So you open your mouth, and what do? You snore. So one of the first indicators that you might have sleep apnea is snoring. There are very few people who have sleep apnea who do not snore. There are some people with something called central sleep apnea that won't snore, but the majority of people snore. The louder the snoring, the more the having to wake up and gasp for air, the more you worry that you have sleep apnea. The universal sign for sleep apnea during the day is daytime drowsiness. You sit down to read the paper at 1 o'clock in the afternoon, before you know it, you're asleep. That is a sure indicator you're not getting enough sleep at night, and there must be a reason that you're not getting good quality sleep. When you do go to sleep at night, it's important that you don't do certain things. So if you drink much alcohol close to bedtime, that makes your tissues more relaxed also. All the muscles relaxed with alcohol. So within 3 hours of bedtime, you should not be having any alcohol, and hopefully just a glass of wine or something in the evening, nothing more than that. Secondly, if you're taking a sleep aid, if you're taking one of the Lunestas or Ambiens, something like that, or even the ones like Valium or diazepams, or those kinds of drugs, you can have relaxation that will make your tissues more floppy too. So there is an issue of the University of California, Berkeley Wellness Letter that I have up here, and this is also online. I think it's free online. I think you can dial it up, but it's just on sleep apnea, and it's a very good issue on that. So if you suspect you have sleep apnea, or a loved one thinks you have sleep apnea, the first things that you do is you have somebody observe you while you're sleeping and see if you're stopping breathing. If you're stopping breathing for longer than 10 seconds, and you're doing that for more than 5 times an hour, then you have to say, well, you probably do have sleep apnea. If the screening, that's just a basic screening way of wondering if you have sleep apnea, then you go to a doctor and you ask them, can I have a test for sleep apnea? So there are 2 tests that are available out there. The first test tests you for your oxygen levels all during the night. That's called a SNAP test, and that can be done at home. That can be set up by your doctor locally here, and you wear one of those little pulse oximeters on your finger, and they find out about your oxygen level all night. And if your oxygen level is dropping below 90% consistently, then you need to have a further study. If your oxygen level stays good all night, you got no problems. If your oxygen level does go down, then the next thing you do is you get a polysomnogram. So that's a full-fledged sleep study. They find out how your heart rate is, they find out how your breathing is, whether your chest excursions are good, and the more sophisticated ones do EEGs to find out how your brain activity is too. If indeed you're diagnosed with obstructive sleep apnea, then you might end up, as this gentleman here, and in the older age group, it's usually men, so he's got his gray hair there, so he's older. So men, usually if his neck circumference is greater than 16 and a half, 17, he's got about a 90% chance of having sleep apnea, which is interesting. And so you end up with a CPAP, or a continuous positive airway pressure machine, to help get more air into your system when you're sleeping at night. And these can be refined so they can just be in the nose alone, so that not the big apparatus here. Some people can never get used to these. Some people take to them like a duck to water. When they go camping, they got their battery pack with them because they take it on their camping trips. I had one guy here in town had 4 of these units. He had like 2 homes, and he had the extra homes, and he put them in there, and he used to go out in his trailer a lot, so he had one in his trailer, and he had one at home, and wherever he went, because he enjoyed it so much that he got such good sleep, he felt so much rested the next day, so different than he had been when he was not using his CPAP. Other people get claustrophobia. They're pulling this thing off during the night. We send them into Apria or to see Noble Weidlich or somebody to see if we can get them to do the nasal CPAP. They don't tolerate that. So then I end up seeing them. I end up seeing them again. The reason they come back to me is they want to know, is there any surgical cure for this? So the first thing to remember about obstructive sleep apnea, all of the studies show this is your best bet. CPAP does better than any surgery, period. All the surgeries devised, whether it be jaw thrust forward, bringing your tongue forward, straightening your nose, trimming off part of your tongue in the back, taking off part of your palate, all those things, getting a lot of scrunching of faces back there. All those things that can be done, none of them does as good as this machine. And it's very frustrating to surgeons who like to think they can cure anything. So I see the people who absolutely refuse to do the CPAP. So the first thing I look at is the nose. Can you breathe through your nose easily? Because a lot of times they have enough obstruction of their nose that makes this machine so it won't work as well, and they have to turn the pressure up real high, and they don't like that. So I just straighten out the inside of their nose, and they go back to the machine, and they're happy. Second thing I look at is tonsils. Look at the roof of their mouth, see if their uvula is hanging down, and then if they have big problems there, I do what's called a uvulopalatopharyngoplasty, which is take off the top of the soft palate way in the back with the uvula, take out their tonsils, and open up their nose if there's any question about that. Now that is a painful operation. I don't know how many of you have ever had that done, but the first couple of weeks, you're not a happy camper. I'll have to say most of the patients afterwards are much more happy with how they can breathe. Some of them still have to go back to the machine though, because it doesn't cure them. As I say, the machine is still the #1 way to cure it. Now, when you think about sleep, and no one knows exactly why we sleep. It's been hypothesized it's to give our brain a rest. It's hypothesized to give our muscles and nerves a rest. But no one has ever come up with the reason, and all the researchers, and it's quite miraculous. I mean, you watch a baby sleep, it's just so restful. And when you sleep yourself and you have no memory unless you have a dream or something, and yet you wake up and you're rested. And so why do you sleep? And what caused you to sleep? Well, melatonin is a thing released by the pineal gland that's inside your brain. And melatonin starts to be released when it gets dark. And so as it starts to get dark, melatonin is released, and melatonin helps make you sleepy and helps make you want to go to sleep. So therefore you see at all the organic stores melatonin. That doesn't work quite the same. We wish that it did, but it does not. But you've probably seen melatonin. It's used for jet lag. It's used for people who have insomnia. We'll use melatonin because it's pretty innocuous, and you can certainly give it a try. But melatonin helps us go to sleep. As we get older, we make less melatonin. We don't sleep as well. It's probably half of people over 65 have some degree of insomnia. They're waking up during the night. They're not able to go back to sleep. Things that we try probably aren't good. The sleeping pills that are on the market, you have to be very careful of all of them. You want to take them not regularly, because you will get addicted to those, and then when you try and go off, you'll have a terrible time with insomnia for a long period of time. So you want to go easy on the sleeping pills. You want to go easy on the over-the-counter stuff, the Benadryls, the diphenhydramines, because there are a couple things there. For older men who have prostate problems, they'll take a Benadryl and they find out they can't urinate when they get up at night. And that's because it has a direct effect on the prostate, and then you got yourself a problem. You're awake, and now you can't urinate. And hopefully that goes away so you don't have to go to the emergency room and get catheterized. So the medicines that are out there for sleep, I just caution you against those as much as you can. The things that help with sleep that we know of: regular exercise. I mean, how many times do you hear regular exercise? Regular exercise helps this, helps that, helps this. It does. It helps you go to sleep if you have regular exercise. Regular exercise should not be done close to the time that you're going to bed. It should be done during the daytime. Having a schedule for your sleep. So if you like naps, you take your nap before 3 p.m., you only sleep for 30 minutes, and that's all your nap is going to be. If you take a longer nap and you take it after 3 p.m., all the studies show you're more likely to have trouble with insomnia. So if you're going to take naps, take short ones, take them early. Alcohol, we've already talked about. Probably a glass, try and get it in there at least 3 hours before you're going to go to sleep, because alcohol isn't good for sleeping. The bedroom, it shouldn't be for watching TV. It should be for sleeping and for sex, and that's it. You just have to have your bedroom designated. This is a place where I sleep. And that's important too. Sometimes elevating the head of the bed is helpful for sleeping, especially as we get older. And elevating the head of the bed doesn't mean a couple of pillows underneath your neck. It means either a wedge from your waist up, or taking some bricks and putting it under the bedpost at the head of the bed, elevating about 6 inches so the whole bed is up some. There are a lot of reasons that helps people sleep, but that seems to help. You want to sleep on your side if you can. You'll get oxygen more easily on your side. On your back, you're going to have more chances of obstruction. So those are just some of the things, but there's a whole list of things that you want to do regularly to try and keep yourself in a pattern so that you'll sleep regularly. You don't want to eat a big meal before you go to bed. You want to eat at least 2 to 3 hours before you go to bed. And pretty soon it sounds like a regimen, like who's going to do this? Well, if you enjoy sleeping, you'll find that you'll want to get into the habit of doing these things. Believe me. We're going to move on to the lips and mouth and tonsils. So this is a section, a coronal section of the tongue, which is here. This is where the uvula is, the thing that hangs down here. So when you first enter medical school, they tell you the one thing you have to know to graduate is on the final exam, you have to be able to tell them what that is. And I said, really? And the guy said, no, not really. So this is the uvula hanging down here. These are the turbinates we were talking about. And down here is where your voice box is. This is the epiglottis. This thing closes off when you swallow, so food doesn't go down your Sunday pipe, down into your trachea. And then the esophagus is here, and air goes down here. At the lip level, right here, if you get something looking like this looks like a cold sore, or it looks like what we call a herpes simplex, but it doesn't heal, then that most likely is a squamous cell carcinoma. So this is different from the one you got on your nose earlier. That was a basal cell carcinoma. This is a little more serious right here. These right here are also caused by sun exposure. Can also be from smoking, where you put your cigarette in the same place all the time, or a cigar in the same place all the time. These here, if they get a good grip, can drain into lymph into your neck, and you will have a lump in your neck suddenly. So that's a metastatic deposit of squamous cell carcinoma. Now, that means it's gone from the lip down into the neck, into the lymph system in your neck. And that gets to be pretty serious. So if you have a sore like this, and this doesn't heal after a couple of weeks, that needs to be investigated. That one you need to act on a little more promptly than the nose even. So I don't know if any of you have ever had a squamous cell carcinoma in your lower lip. So this one right here, typically, it would get a resection. So there would be an incision here, and an incision here, and it would go down like this in a V, and take out that, kind of like taking a piece out of a pie, and then you would suture that point to this point over here, and a year later you couldn't even tell that they had an operation. They'd have a thin scar there, and that would be about it. So you can do that with up to a third of the lip. So you take out a third of the lip like that and then put it back together, and you can hardly tell. I don't know if you're going to be eating Big Macs, but you can definitely get a good cosmetic result, meaning you might not be opening your mouth as wide as before. So those right here need to be taken care of sooner rather than later. This is tonsillitis. I'm sure some of you had kids that have tonsil problems. So these things right here, here's our friend the uvula. Here's the tonsil, and it's covered with pus on each side. So tonsils and adenoids. The adenoids, if you went straight in and then up, and you can't see them here, you'd have to have a mirror back there and look up behind the uvula, and you're looking up. That's where the adenoids are, up in here, behind the palate. And these are the tonsils here. So a lot of kids come in and they're breathing. They can't close their mouths. And the reason they can't close their mouths is the tonsils are big, and then the adenoids, when you take an x-ray from the side, you can see the adenoids are so large, they've cut down the nasal airway. So now they don't have any airway coming in here. They got this little area here, and they don't have any air coming through their nose because it goes to the adenoids, can't get any further. They got snot dripping out of their nose, and so they need to have their tonsils and adenoids taken out. When a teenager comes in and they have this kind of problem, if they have it more than 4 times a year, they need to have their tonsils out. But we're pretty strict on 4 times a year because most of the teenagers will outgrow this as they get older. Some of them don't want to hear that. They just want to get rid of them. But if they've undergone a tonsillectomy or they've heard about their friends who have undergone a tonsillectomy, they won't be so quick to do it. Tonsillectomies hurt. They're just, I've had to do those on adults sometimes, and they'll say, you know, I've had babies, and this was worse than having a baby. It just hurts, and it hurts for a while, and finally it gets better, and they're very happy they had it done. So we're very slow to take these out unless they have a good 4 infections a year. And that usually looks like this. It's red, it's pussy, and sometimes it involves mononucleosis, which you've probably heard about. You get lumps in the neck, you don't have any energy, your spleen gets big, and that can go along with tonsillitis too. So tonsils and adenoids are mostly kids' problems, but you want to be slow to do something about it unless there's airway obstruction or they're having repeated infections, more than 3 or 4 a year. Next thing we're going to look at, 2 things. One is similar to something I had today. So this right here and this right here, these are vocal cords. So if you were to take and you were to put a scope, a fiber optic scope, down your throat to go toward your voice box, you would be looking at vocal cords. And the vocal cords, as you talk, they move back and forth. And if you have smoked a lot and you got unlucky, you end up with this right here, and this is a cancer of the vocal cord. So this is on the left true vocal cord. This one over here is perfectly healthy. You can see it's nice and shiny, but this one has this growth right here. So this is almost always linked to smoking. I don't think I've seen one in my practice where the patient has not smoked. So smoking is a bad thing, and I know everybody gets tired of hearing that, but I don't think we can preach that enough. Smoking is the one worst thing you can do in your life because you can end up with things like this. This is very curable. You take it off in the operating room, and then usually they get radiation treatments, x-ray treatments from the outside. Dr. J. Joseph, our radiation therapist in town, cure rate's way over 95%. But it's caught early. So this is an early squamous cell carcinoma of the voice box, so it's just involving the vocal cord. Presentation, hoarseness. You wake up in the morning, you can't talk very well. You think, oh, you know, I've got laryngitis. You know, 2 months later, you're still not talking very well. Well, laryngitis doesn't go on for 2 months. Some people will come in and there'll be 6 months they haven't been able to talk. And I'll say, why didn't you come in? Well, I was afraid it was cancer. Well, duh. I mean, this is why we're here. So come in before 6 months. You know, don't give it that long. But this is the presentation when you have hoarseness and you have a vocal cord carcinoma. This over here is probably the most common thing that you see advertised on TV anymore. GERD, gastroesophageal reflux. So what's going on here? I think everybody's heard about this, but what's happening? So this is the esophagus. This is your swallowing tube. And now we're way down near the stomach here. And as it goes into the stomach, there's something called the LES, or lower esophageal sphincter, right here. And that is to keep things in your stomach. So here's your stomach. It's all loaded up with liquids and stuff. And then the pylorus, this is another valve, and then stuff will go down into your intestine and go on through. When your lower esophageal sphincter is open, like here, stuff goes back up. Most commonly, you'll be lying down. When you're standing up or sitting, you got gravity working with you. As soon as you lie down, again, if you've had a lot of alcohol that relaxes that sphincter, or you're taking medicines that relax that sphincter, or if you have a hernia here where this is actually dilated some, so the sphincter can't work, that's called a hiatal hernia, this comes back up. So what symptoms do you get? You'll come in to me and you'll say, it feels like there's something in my throat. I got to clear it a lot. And I go to talk, I'm a little hoarse in the morning. I have to clear my throat some more. And then as the day goes on, I notice a little burning sensation here, because most people get pyrosis or they get a little heartburn with this. And if this continues, the hoarseness gets worse, they're clearing their throat more, and it's because of problems down in their stomach that are refluxing up into their throat. It doesn't have anything to do with the throat per se. So this is called gastroesophageal reflux. So what do you do for this? There are several things that you do. One, you be conservative to begin with, and you don't take medications. I think that the PPI drugs, so the PPI drugs are the proton pump inhibitors. These are the Nexiums, the Prilosec, all of those things that you're reading about in the paper that everybody wants you to buy. You can buy them over the counter now. Best not to do that first. First thing you do are some simple things. One, you have your largest meal at lunchtime, if you like large meals. Dinner time is light, so again, when you go to bed, your stomach is empty. Two, you elevate the head of your bed, like we talked about for other problems. And then three, no alcohol prior to bedtime, and maybe a couple of Tums at bedtime, and leave it at that. And see how you do. Sometimes just changing your behavior, just doing some behavior therapy here, works enough that this goes away. If you're real heavy, you should lose some weight, because when you go to sleep and you got your stomach weighting this down, it's more likely to push it right on up your esophagus. Now, if that doesn't work, then the proton pump inhibitors do a good job. And what they do, what those medicines do, like Prilosec or Nexium, Nexium is the purple pill, it cuts down on the acid production in your stomach. And that's a good and a bad thing. It's a bad thing in the sense that the acid is your first layer of protection against infections. So say you go to Tomaine Tommy's and you get a good dose of some E. coli there. The acid in your stomach is the first line of protection to destroy that E. coli so that you're not going to get really sick. The second thing that happens was in the Chronicle just this last week. It shows that vitamin B12 is not being well absorbed if you're taking Prilosec or you're taking Nexium. And so pretty soon vitamin B12 deficiency develops. You develop an anemia, you can develop dementia, and you can develop other neurologic problems. So you want to take these drugs with great caution, and you want to have somebody watching over you when you're taking these drugs. You don't want to be taking them freely and for long periods of time. I think it's like any medications. They got to be taken seriously. I mean, the medicines we have are miracle drugs, but they just have to really be respected as to what they can do. So GERD is best treated first with some behavior modification, and then secondly with a proton pump inhibitor. And then thirdly, if you're not getting better, I send you to the gastroenterologist, and they look down there to make sure you don't have some other things going on that possibly may have to be treated, such a hiatal hernia, which might require surgery to help that. The last thing we're going to talk about is thyroid. Whoa, there we go. So thyroid lumps. So if you lived in the Midwest in the 1800s, you were almost guaranteed to have this. Because in the Midwest in the 1800s, they weren't getting the iodine in their food. And they didn't have iodized salt. That's why we have iodine or salt. So that you got plenty of iodine so that you can make your thyroid hormone and you don't develop a lump where your thyroid's trying to make it and it doesn't have any iodine. So that's called a goiter. Goiter just means thyroid enlargement. And so a patient comes in and they have one of these. What do? It's pretty straightforward anymore. It used to not be so straightforward. So in 1975, this lady was going to surgery, basically. I had to take that out, find out what it is, and find out whether there's cancer or not. Now we have the ability with ultrasound and with needle biopsies, you can have a needle put into that, ultrasound guided, and Dr. Gordon, our pathologist, can look at it underneath the microscope, and he can tell you whether it's cancer, not cancer, whether it's something called Hashimoto's disease, or whether you need to be on medicines, or what needs to be done. And that's a huge leap forward. Medicine has made so many great leaps, but that really helps people who come in with a lump right there and they're worried whether it's cancer. I can tell them in 2 weeks whether it's cancer or not and what we need to do with it. The thyroid itself is kind of a butterfly-shaped gland that overlies your breathing tube. Here's your voice box here, here's your trachea here, and it's in a critical place because there are two nerves running through it. One controls the voice box on one side, one controls the voice box on the other side. If you have to have thyroid surgery, you always run the danger of coming out with hoarseness because that nerve on either side can be damaged, bruised, sometimes cut. And so you want to do thyroid surgery only when you have to. But bottom line is you get a thyroid lump, you go right to an ultrasound, get a needle biopsy, find out what it is and how to treat it. And that's kind of the end of my lecture. Questions and answers. If you have questions, I might have an answer. Yes?
Can you talk a little bit about asymmetrical loss in hearing?
Sure. So, yeah, let's go back here. So the question is, can you talk about asymmetrical hearing loss? So some people, when they take the hearing test, they have a, whoops, come back here. They will have one ear where the hearing goes down, and then the other ear, it'll be right across here, normal hearing. So they will come in and they'll say, you know, I don't think I hear as well in the right ear. I've got some ringing in there, and it feels a little stuffy to me. And so we'll get a hearing test, and it will show exactly that, an asymmetric hearing loss. So the first thing that happens is they have just bought themselves an MRI. So an MRI is a test using magnetic resonance imaging, so it doesn't use X-ray. It won't harm you at all because it has no X-ray in it. But it is looking for a tumor in the internal auditory canal, which is the inner ear, because the most common presentation is an asymmetric hearing loss like you're talking about. You have to get that one off of the discussion plate right away because that's something that can kill somebody. So you got to get an MRI. Once the MRI is okay, then you can talk about the other things. And one is Meniere's syndrome. We have a patient here in the audience who has Meniere's. And so Meniere's is usually unilateral. You usually get hearing loss in one ear. Next thing, genetic. A lot of people are born with hearing only in one ear, which is interesting. They do well through their whole life. They don't have stereophonic. They can't tell as much where sound is coming from. But they do well in terms of conversation, in terms of school, and that type of thing. If you have had trauma, maybe you've been hit in the ear, maybe you've had a hole in the eardrum, that can cause an asymmetric hearing loss, or if you've had chronic infection, it can cause you to have an asymmetric hearing loss.
So maybe just one infection or two infections in your life?
Absolutely.
Really?
Yep.
Can I ask an added question?
Sure, absolutely.
Because I did see Dr. Spence, and
Yes.
I have to have that, and like, been really afraid of it. I know. I got
Are you claustrophobic?
a little bit. I had to have an MRI once, and it was awful.
Did you take a little Valium, or did they give you anything
I will
for
this
it?
time. Last
Good.
time I was brave, and
Good.
it was the stupidest thing, because it was just a terrible experience.
Valium helps a lot.
Yeah, I'm sure it will
Sure.
this time. But when she told me that, I think sometimes when you're listening to a doctor and you're trying to really pay attention, I walked out the door because she said if there's possibly a tumor that, because I said to her, well, if you had a tumor, wouldn't you have pain or wouldn't you know? And she said, no, but you'd have symptoms somewhere else. And at that point, I walked out the door and couldn't remember things she said about that.
And that's very common.
Oh, that's good because
Yeah.
I thought, how could I forget such a
No, that's
thing?
very common. You know, when a lot is being thrown at you at once, it can really be tough. So, in answer to your question, it's not only an acoustic neuroma, which is the tumor inside the inner ear, but you could have a brain type tumor too on that side of your head, and that's when she's talking about other symptoms. So you could have trouble swallowing, you could have trouble moving your tongue correctly, so you're having a little dysarthria when you speak, it doesn't come out clearly, things like that.
Something obvious in your head.
Something obvious,
Okay.
yeah, something obvious.
Okay,
Yeah.
thank you.
But an asymmetric hearing loss, you got to have an MRI.
Yeah.
Yes, way in the back.
An acoustical neuroma, when it's taken care of properly, only leaves you deaf and you know that probably that it's it.
That's correct.
And I'm very good proof of it, that it,
What did she say?
Yeah.
So she said that an acoustic neuroma only leaves you deaf in the ear that it is in, which is true. So this is the tumor we're talking about in the inner ear, and that she is proof of it. So does that mean that you had either gamma knife or you had surgical removal?
that your office diagnosed me not that fast with having it, and then I had the operation of the house ear,
Yep.
and
So that was done at the House Clinic in Los Angeles?
this was done at in hospitals in Los Angeles.
Yep.
And it was a large tumor pushing into the brain.
Yep.
And the only thing that's left for you is a deaf ear.
Yep, that's exactly right. So she had an acoustic neuroma, which is the type that you get in the inner ear. She came in, probably had a hearing loss on one side, and she said we diagnosed that, and she had it done. Was it the Good Samaritan Hospital, Los Angeles? Do you remember?
No, it wasn't. It was downtown. It was right across from where house ear was then. This was in the 80s, 1980s.
In the 80s, okay, yeah.
But I came into your office and that.
Good. I'm glad to hear it.
I was so shocked.
We don't want to learn that we missed something like that. Yeah, Ben.
As an alternative to CPAP, I've heard some kind of discussion of what I think are called nose flaps or nostril flaps. Are you aware of these? They're basically, they open and close a lot and act the same as a CPAP to keep the nasal passages open.
So that's also with positive pressure, meaning they're also under pressure. And that is kind of the nasal variation of the mask. And there are more and more of those being developed because so many people don't like the complete face mask. They have to struggle with that. Yeah, but yes.
If you're sleeping at night, and then all of a sudden you wake up, gasping for air, is that one of those instances when your heart is stopping and then you just tell your body, hey, wake up?
No, what's happened is your carbon dioxide level in your bloodstream has built up to a high enough level because you're not taking adequate breaths that it wakes you up. So that your brain is responding to carbon dioxide in your bloodstream and saying, wake up and get this guy breathing. But it doesn't have anything to do with your heart, it doesn't have anything to do with your lungs per se. And that's not unusual situation. If it happens a lot, you really should have a sleep study.
Ringing in the ears, would you talk a little bit about that?
Sure. There's nothing that can be done for it. I wish I weren't so blunt. But if you Google tinnitus or ringing in the ears, you'll get about 10 million hits. And the reason you do is that there's no cure. So if you Google carcinoma of the lip, you'll get about 3 different ways of treating, that's it. Tinnitus, probably the tinnitus foundation that's in Portland, Oregon is the best website for that to give you ideas of how to cope with it. Tinnitus can be severe where you cannot abide it. It keeps you awake at night. It can be unilateral or it can be bilateral. It can be high-pitched, low-pitched. I had a lady the other day that had a foghorn noise in her ear. So the variation is huge in terms of the noises you can hear. Masking is a great way to try to make your brain not listen to it. So at nighttime, your radio's beside your bed, You put it on FM, you turn between the stations, you now have tuned in white noise. White noise generators you can also buy, but between the FM stations is the same. The white noise masks the sound in your head so that you're not as aware of it, so you're able to go to sleep. If it's bothering you during the daytime, you can get something that looks like a little hearing aid that also puts in a little sound that tries to mask out the sound that you're hearing. So we try and tone match the level. Say you're hearing middle C, we try and find that out, and then we have a way of cross-matching that so that you won't hear that middle C. But the only problem is you can't hear out of that ear because you've now got noise being generated in there. There are no medications. There are a lot of them that have been tried. There are no medications that are going to affect that. It has to do with the cochlea in your inner ear, and it has to do with the little hair cells. Usually is age-related, but
Trauma related to, I mean.
can be
mine
related.
started- I have 3 or 4 different tones, but the main one started with firing a gun 50 years ago.
Yeah, that's right. I see a lot of guys from, well, even World War II, but also Vietnam who walked in front of a howitzer and, and had a blast go off beside there, and they've had tinnitus since then on that side because you've blown away a lot of the hair cells in your ear and the response of your inner ears to create noise. But there's no one cure for it, unfortunately.
Is it like a precursor to deafness? Because I hear or have read that was like one of the first signs, this ringing or whatever, and then they eventually.
It's one of the first signs that you're losing some hair cells, and losing hair cells is a precursor to deafness, yeah. But I don't want to leave you with the impression that means that you're going to wake up tomorrow unable to hear or anything like that. It's a very gradual type of process. It doesn't happen quickly at all. Yes?
Can you explain a little bit the difference between a goiter as you pictured and a multinodular?
Sure.
goiter?
So the question is, can you explain the difference between a goiter and a multinodular goiter? So if we look at the goiter here, so a goiter, the simple definition of a goiter is an enlargement of the thyroid. Nothing more, nothing less, just means an enlargement of the thyroid. When you have multinodular, you would have to picture the skin has been taken away. You would see little lumps. And so there would be multiple marble-like lumps in the goiter. So now we call it multinodular. And what does that mean? It means that it's much less likely to be cancer right off the bat. So very few multinodular goiters are cancerous. They're almost always benign. They're usually a reaction to some microhemorrhages inside the thyroid, where you'll have a little blood vessel that'll pop, and then you'll get a lump, and that will form a nodule. It can also be cystic, so there are certain cystic conditions of the thyroid that can do that. But normally they don't need to be operated on, and normally you don't have to take any medications for them. You do need to find out if your thyroid's working normally with a blood test. Make sure it's working okay. It usually is, but you don't have to do anything about it. Mm-hmm. Yes.
So if you have uneven hearing,
Yes.
I had uneven hearing, so I went to the audiologist and got hearing aids. Should the person go to you or Dr. Spence first when you have uneven hearing in your ears, or you said something about an MRI and all
So
that?
yeah, so when you're saying uneven, you're saying one ear is hearing
This
better
is
than the other.
lesson.
Yeah. You really should. You should let us see you first.
I see.
Yeah, let us see you first to make sure you don't have something simple. You may have just a very small film of wax over one eardrum, and that will also produce uneven hearing or discrepancy. So it can be something simple.
No, Dr. Spence had already, every 3 months I get that.
Get it cleaned out. And you had a hearing test, and it shows one ear is worse than the other?
Yes.
And did she talk to you about possibility of looking into that further?
No, I just rev up this ear.
There you go. That's another solution. But you might ask her next time you see her.
So you don't, I mean, see Dr. Spence?
Yeah.
Okay.
Yeah, for
So,
sure.
Now I lost my question.
That's okay. That happens to me too.
Oh, I
Yes.
can't feel anything then. You can't feel this tumor.
No.
I mean, it doesn't feel like anything's wrong with
No.
it. I just couldn't hear.
No. And if you
Okay.
talk to the lady back there before she had her surgery, she did not feel pain. She didn't feel like, but she did feel like there was just something wrong with her hearing. Yes.
Yes, sometimes it hears buzz, like somebody's pumping a tire or something. One of my ears buzzes like mad.
Which ear?
Sometimes it's this one, and sometimes it's this one.
Now, I've cleaned your ears before, haven't I? Yes.
Thanks a lot.
Yeah. I think you're going to have to come in again. I got to clean your ears again. When it buzzes, is it the hearing aid or is it the inner ear, do you think?
The ear.
The ear itself.
Yeah.
It still could be some wax.
Oh.
Yeah, it could be some wax. When you get a wax impaction in there, you don't hear things around you, so you hear more inside your head. And inside your head, we all have a little bit of buzzing going on. But you might hear that more now because it's plugged up. So you might want to come on in.
Thank you.
Yes?
Can you recommend something to help with snoring?
We'll talk about that when you come in. That's a lengthy subject. Yes?
Can you explain the difference between insomnia and sleep apnea?
Sure. So insomnia is the inability to either get asleep or stay asleep for a period of time. So if you want to sleep for 8 hours, either you can't get to sleep or you're waking up and you can't get back to sleep. So apnea is the sensation of breathing. Apnea just means sensation of breathing, cessation of breathing. If it's obstructive apnea, that means your cessation of breathing is caused by some obstruction in your nose, your throat. So obstructive sleep apnea would be that you're stopping breathing because of an obstruction. And insomnia would mean you're just not staying asleep or you're unable to get to sleep.
That's me. I wake up in the middle of the night and then I have a hard time going back to sleep. But I know that I'm doing a sleep study, right, with the doctor. And
Yep.
I sleep on my side all the time. I don't snore and I've never waken up gasping for air, right?
Yep.
So I don't know if I actually have sleep apnea or not. They're still testing me for it. They're trying to, but I don't have some of those symptoms of apnea, right? But I do have a hard time going back to sleep, or I don't go back to sleep.
So if you're seeing, I don't know if you're seeing a pulmonologist like Dr. Steele or Dr. Belagorsky or, I don't know.
It's a sleep center in Santa Rosa.
In Santa Rosa? So it's probably Belagorsky or Steele. So they will talk to you about insomnia also. So if you do not have apnea, ask them about insomnia. They can give you clues about how to help that.
They did one test, but I sleep on my side, right? So then they wanted me to come back and sleep on my back, right?
Mm-hmm.
So they can see if they can get more results or something, or show more if I even have apnea or something like
Mm-hmm.
that. But I don't sleep on my back, and I have a hard time going to sleep on my back. And immediately when I get ready to go to sleep, I just automatically roll to my side and sleep, right?
Well, they're just not going to get that data.
Yeah,
But if you have no apnea on the test, then you need to ask them about,
yeah.
the insomnia thing. Yeah, Ann.
Well, I'm one of the people who's not taking this CPAP machine like a duck to water. It's kind of haunting me in my nightstand these days. And I have a friend down in Berkeley whose husband had went to a place down there and got some kind of apparatus that he wears in his mouth. And Dr. Steele doesn't think much of those, and I'm going further with him on that. But do you know anything about those or opinion on those?
I do. Forget about those expensive over-the-counter oral devices. They don't work and can cause mouth and jaw discomfort.
Well, it's something they gave him at the sleep center. I mean, it's not something you get over the counter or something.
I think they're getting desperate. And my experience is the little amount of improvement that they give you is not worth the problems it creates in the jaw joint. It's predicated on moving the jaw forward, and as you move the jaw forward, you carry the tongue forward. as you carry the tongue forward, it opens up your airway so you can breathe more easily. But picture yourself with your jaw forward all night. That doesn't do wonders for your jaw joint. And the next thing, you got jaw joint pain. There is an operation that is designed just to bring your tongue forward. They put a big suture through your tongue and then bring it and tie it to your mandible here in the front. And so it pulls it forward. Yeah. I could see that was going to be a hard sell. I could see the look in your face. No, you're not going to get that. But I don't think that would work, Ann. Pete?
Yeah, on the lighter side, I got a sneeze. I'm in this lecture learning about some medical terminology and all of that. And I find if I take my finger and push it against the bottom of my nose, it suppresses that sneeze.
Don't you dare ask me why.
Yeah.
I have not a clue. I know that if you look toward light, it'll help you sneeze, but I have no idea about that. Yes.
Yes. Recently I just had an upper and lower procedure. And I've been coughing. My lower procedure, they did on some polyps. And then when they did it on the upper one, they did notice that I do have a hernia in my acid reflux.
Okay.
And I asked the doctor, why am I coughing constantly? And it's making this sexy voice, you know.
Mm-hmm.
And also, when I eat, I cannot eat properly. I have to eat very slowly. And if it's a meat, I have to cut it very finely, or else I feel like I'm choking. Now, I did make an appointment in your office next week. But being you are here, would you kindly tell me what can I do in the meantime?
So when you say that they did an upper and lower procedure, so they looked down your esophagus, down your swallowing tube,
Correct.
and they said you had a hiatal hernia, you had a hernia down there
Yes.
that was allowing reflux to come up here.
Yes.
And so what did they say was going to be the cure then for your reflux?
Well, that's why they asked me to see either you or Mr. Dr. Spence.
Dr. Spence?
I asked for you, but you're busy, so I got Dr. Spence.
Could I add to it, Doctor?
Yeah.
The regimen that they're recommending is dietary. In other words, my wife needs to avoid certain foods to help
Lots of food.
cut down on the acid reflux.
Okay.
Because I think that's the main situation.
Any other suggestions they had though in terms of like the elevation of the head of bed and not eating prior to bedtime and avoiding certain things and any medications they wanted you to take or not take?
I have been taking Singular and
Anything?
Delura and Pro Air when needed, only 4 times a day, but the Delura twice in the morning and twice in the evening. It seems like I am still coughing and I still have this sexy voice and I cannot eat very well.
So the
and
cough.
It bothers me.
Mm-hmm. So the coughing and the sexy voice are almost always caused by the acid coming up into your voice box, irritating it, causing it to make you cough, and also making it hoarse. So the trick is to shut off the acid coming up. And so far, the only thing I'm hearing is they're changing your diet some. Did they say you needed to have the hernia reduced or operated on to close it so you wouldn't get reflux?
Dr. Hannah,
Z. Hannah, yep.
said that my hernia is small.
Ah,
It's not large.
okay.
But he said that he can see that I do have problem with my acid reflux. And there's a hernia.
Yep.
And he also mentioned that my throat, there's something like clogging it. Like it's not open like it's normal. It's like, closing in. And so I said, okay, I want this done because this has been going on for many years. As I get older, it got worse.
Getting worse. Have you seen a gastroenterologist? Did you see Dr. Hansen or Dr. Matosian?
I saw Dr.
Hansen?
No, Hannah.
Hannah. No, I know in the past though, you say it's been going on many years. Have you
Yes.
seen a gastroenterologist, a specialist in GI problems?
Matosian.
Matosian.
I saw him, yeah. And I also saw a doctor, his name is Dr. Smith, but he no longer works here. He's in Oregon.
Yes, he
did
is.
something that he proposed
Yep.
my
Yep.
stomach, and somehow that one did help me. I wasn't coughing, I wasn't throwing up, you know, I was not, I have my lovely voice again, but, and then after so many years,
Well.
it's back again.
I hate to say it, but I think it's more complicated than I can offer suggestions this evening. I think you need to be examined and let me look down your throat and everything.
Well, that's what
I'm sorry you're having so much trouble though, yeah.
Yeah, and I mean, a lot of,
If it were just the voice and you weren't coughing, you'd probably be happy, huh?
I'm sorry,
If it were just your voice like that and you weren't coughing all the time, you'd probably be okay with it, huh?
probably so, but I miss the singing in the church.
Ah.
My voice
Well,
changed.
you need to be examined in the office.
Yes,
yeah.
I truly hope and pray that you folks can help me,
I do too.
because I'm not getting any younger, you know.
No, none of us
So
is.
I
You're right.
want to-
That's-
I want to enjoy my life.
That's right.
As much as I can.
That's exactly right.
But when I'm coughing so hard.
Yep. So I'm getting a sign from the crowd back here, the directors and producers, that it's time to cut it off. And thank you so much for coming out. It's very nice of you.